Thank you so much, Alan. It's really amazing to be back here. I have a lot of very, very fond memories. I don't think I've been in this room for 12 years now, 13 years, something like that. And I'm so grateful for the time that I spent here, the mentors that I had and continue to have. Certainly Alan and Nick, and it was just a really wonderful foundation. And for all the residents, you are in an amazing, amazing place. And I'm really happy to be back here. So as Alan mentioned, I'll be talking about my clinical and translational research in pediatric hearing health disparities and health equity today. I'd first like to start by acknowledging all of my colleagues and collaborators through the Children's Communication Center at UCSF. These are clinicians in otolaryngology, head and neck surgery, audiology, speech-language pathology. We have an amazing team of care coordinators and research coordinators who make all of this run. We're funded by the NIDCD and by PCORI. And at the bottom here are all of the students. These are post-bacs, medical students, residents that are currently working with us. I have learned so much from them over the last 10 years, and a lot of the research and these directions that this research has gone has been driven directly by what I've learned from the trainees that I have had the privilege to work with. And you'll see many of their names come up during this talk. So when we normally think about translational research, right, we talk about translational research a lot, right, and the concept of bedside to bench and back to bedside. And the foundation or the model of clinical research is that we as clinicians have some kind of clinical insight, or we develop some clinical insight based on the practices that we have and the patients that we see. And then we go to the bench, right, to try to identify the underlying mechanisms that might cause that disease. Right, and that's the discovery phase of translational research. And then once we identify those mechanisms, we can develop therapies that address those mechanisms so that we can treat the disease. And traditionally, when we think about translational research, we think about this from a cellular or molecular standpoint, right? We want to identify the pathway that leads to cancer, right? And we want to try to develop a drug that targets that protein or gene that causes that cancer. But translational research can mean many different things, right? We can identify physiologic or anatomic mechanisms, right? Not something that's specifically molecular or cellular, but something that's happening in the body. Or it could be neurologic or even behavioral, right? There are behavioral aspects of human behavior that can directly impact disease. But we can even go further and think about translational research for sociodemographic or health systems research, right? These are all different kinds of fundamental pathways or mechanisms that directly affect human disease and outcomes. And so we can take a translational research model or translational research lens and apply it to sociodemographic and systems and disparities research the same way that we can take it to apply to basic science research, right? But rather than doing a single-cell RNA-seq study, we might do a large database study to understand the behavior of large populations of people. Rather than doing an in-depth immunohistochemistry study to look at the expression of different proteins in hair cells, we can do qualitative interviews with a diverse group of patients and understand their experiences and how they contribute to their child's hearing and development. So I'd like to talk today about how we've applied a translational research lens to health equity and hearing disparities research, and how I believe that is a critical way right now and very impactful way to directly affect hearing health outcomes in children. So the first step, right, is the clinical insight, right? We want to identify an impactful clinical problem, right? That's the first step of translational research, is to identify the problem. And I'm a pediatric otolaryngologist. I spend most of my time thinking about deaf and hard of hearing children. About 6,000 to 7,000 babies are born deaf or hard of hearing in the United States every year. This is probably an underestimate for a number of reasons, but this is the most common congenital sensory disorder. It is one of the most important things that we screen for at birth because of the profound developmental consequences. The cornerstone of universal newborn hearing screening and EDI, or early hearing detection and intervention programs, is this 136 guideline, right? That all babies should undergo hearing screening shortly after birth, with the goal of identification of hearing loss by 3 months and implementation of intervention by 6 months. And this is founded in decades of research. This was the landmark paper by Krista Yoshinaga-Tano showing that identification of hearing loss before 6 months leads to improved language outcomes for deaf and hard of hearing kids, and that there is this window of opportunity within the first 6 months. And this makes identification and intervention for hearing loss a developmental emergency for children. And the fundamental problem here is that being deaf or hard of hearing puts you at significant risk for language delays, and those language delays propagate into permanent developmental, educational, neurocognitive delays, and that the outcomes in deaf and hard of hearing children are highly variable. This has tremendous economic impact, right? So the estimated societal economic cost for a deaf and hard of hearing child without early detection and intervention is over $400,000 in direct educational costs and about $1 million of total lifetime costs. So the estimated lifetime cost for a 1-year birth cohort of deaf and hard of hearing children is on the order of $10 billion, which is actually greater than the estimated lifetime cost for a 1-year birth cohort of children with asthma. Okay. So understanding how to identify and optimize language outcomes for deaf and hard of hearing children is a tremendously impactful need. And because of this, there are systems in place in the United States at every single level to support this. There is federal law governing early detection and intervention. There is legislation and funding in almost all 50 states for universal newborn hearing screening. Educational services for deaf and hard of hearing children are enshrined in the Individuals with Disabilities Education Act, and there are multiple national bodies that govern this system. And the universal goal of all of these is to optimize language in deaf and hard of hearing children by age 3. And so this is the very simple clinical insight or impactful clinical problem, right? That deaf and hard of hearing children are at risk for language delays, and that the language development of deaf and hard of hearing children is highly variable. Right? So we need to find out why. We need to find out what are the most impactful things that can affect the language development of deaf and hard of hearing children. And I can't think of anything that's more important than that for this population that I care about so much. So when we get to the discovery phase, right, we want to understand the mechanisms that lead to variability in language outcomes, and specifically the sort of root and modifiable causes of these disparities, and how we can address them. So when you think about a deaf and hard of hearing child, right, we want to find out what impacts their hearing health outcomes. And this hierarchy from auditory function up through speech and language and development, with language being the sort of most important proximal goal of providing intervention and habilitation for deaf and hard of hearing children. And most of the time, we're clinicians, right? So we think about the clinical attributes that contribute to hearing health outcomes, right? So hearing level, right? It matters more to be severe or profoundly deaf than it is to have unilateral mild hearing loss, right? We think about medical comorbidities, right? If you have Charge syndrome or trisomy 21, that's going to affect your hearing health outcomes. And we focus mostly on the interventions that we deploy and that we have control over, right? We think about hearing aids or cochlear implants or speech and language therapy, or even sometimes the educational services that are supplied to these children through educational systems. But when you look at the actual impact of these interventions, or what we have some control over, right, we see some interesting things. So this is a sort of back-of-the-envelope way of comparing the effects of different kinds of factors or interventions in an outcome, right? So depending on the exact kind of statistical test, you can look at the effect size based on Pearson's coefficient or Cohen's d. And this is a way of sort of comparing apples to oranges to think about how impactful or how much of an effect a particular factor has on your outcome. And for instance, when we look at certain impacts of things that we care about in cochlear implantation, right? And this is work from a bunch of groups, and looking at, for instance, electrode type, right? Whether you use a paramedialar electrode or a lateral wall electrode, there's a medium-sized effect, right? And this is usually has not been shown to be statistically significant in a bunch of studies. Things that have been shown to be statistically significant, right? So if you have a scalar transposition event during your cochlear implantation and you end up with the electrode in either scala tympani or scala vestibuli, right? We think this is a pretty big deal when we insert cochlear implants. And there is a medium to large effect. This is on CNC word score in adults. When we think about modular distance, right, how far the electrode is from the modulus, right? That's something we think about a lot, right? And that also has a fairly large effect. When we look at other things, right? When we look at maternal factors or the amount of cognitive stimulation that a child has, right? This is from the CDA-CI study. This is the seminal study in our field, right, about outcomes for children undergoing cochlear implantation. And this is looking directly now at language. We see that these certainly have large effects. And this was quite impactful at the time when this came out, right, to show that, you know what, with children getting cochlear implants, it really matters what kind of environment they're in, what kind of stimulation, what kind of attention they're getting, right? And these are large effects. One thing that we all know has a major effect on cochlear implant outcomes is implant age, right? So this is from the Lochi study. This is probably the other biggest and most robust prospective study on cochlear implant language outcomes in children from Australia. And the difference between implanting at 6 versus 12 months has a large effect on language outcomes. And this is why we try to implant deaf babies as early as we can. And so when we looked at our own data, and this was just 33 kids, we looked at a very narrowly defined population of kids with babies with congenital bilateral severe to profound sensorineural hearing loss and no other known developmental delays at the time, right? So we tried to isolate out babies whose only issue was their deafness. And these were all children that underwent either unilateral or bilateral cochlear implantation under 2 years of age. And we looked at their language performance at 3 years using a standardized norm-referenced language assessment, the PLS. And what is amazing right now is that deaf children undergoing cochlear implantation truly achieve normal language scores by 3 years of age. Right? We have an intervention that works really well. Right? And when we break this down into children who are implanted early, right, between 6 and 12 months, which is standard of care right now, versus those that are implanted late, 12 to 20 months, those children who are implanted between 6 and 12 months, I'm trying to find on the left there, truly have normal language. They are indistinguishable from typically hearing and typically developing children, right? So 100 is the mean score for the PLS total language for a cohort of typically developing, normally hearing kids. And in the early CI group, you can see that they are literally indistinguishable, right? And this is actually, when I was in residency and starting, we didn't necessarily think that, or we didn't necessarily believe that, but it's true now, right? And when you look at cochlear implant age versus language, this has been seen before, right? That the later you get implanted, the worse your language scores are. But when you look at the SVI, which is the Social Vulnerability Index, right? And this is a composite measure of a number of sociodemographic vulnerabilities, including things like housing instability. This is a neighborhood-coded index. We see that there's a very strong relationship between language outcomes and social vulnerability, right? And that greater social vulnerability has worse language outcomes. This is not a surprise, right? This has been seen by other people in many other contexts. But what is interesting is that when you put this all into a multivariate model, you find that social vulnerability actually has a greater effect on language outcomes than even age of cochlear implantation. Now you might say, well, probably the kids that had cochlear implants later were from more socially vulnerable neighborhoods or were more socially vulnerable. That was actually not the case in our cohort. Okay. So these two things are independently affecting language, right? Age of cochlear implantation and social vulnerability, but social vulnerability actually has a greater impact. And when you put social vulnerability on the same comparison chart with things that we care about as cochlear implant surgeons or can control as cochlear implant surgeons, right? As well as those that we can control in terms of the environment that the child is in, or the thing that we think is the most important thing for outcomes in cochlear implantation in babies, which is implant age. Social vulnerability has a greater impact than all of those things. So we have to reconsider our model, right? And not just think about the clinical attributes or how we can affect those direct interventions to affect hearing health outcomes, but we need to think about demographic attributes. Now, social vulnerability index is a very broad and crude measure, right? It's based on where you live. It's pretty granular. It's down to the census block, but it takes into account a million different factors. Not a million, but probably about 25 different factors. And so what we need to do is to find out what among those factors are actually the most important, and most importantly, the most modifiable factors that impact language development in deaf and hard of hearing children. And people talk a lot about social determinants of health, right? Everyone's heard that term. And I don't like that term because it implies that these social factors are predetermined and then that they determine your health, but they're things that we can't help, right? We can't change that someone is black. We can't change that someone immigrated from another country. We can't change that, a person lives far away from, where they need to get care. But if we can identify modifiable factors, modifiable sociodemographic factors, that's where we can have an impact. And so one thing that we looked at is insurance type, right? So everyone knows that publicly insured kids, publicly insured people have worse health outcomes than privately insured people. And that's the same for language outcomes after cochlear implantation, right? So this was a retrospective cohort study. This was work done by Elizabeth Liao. She was a medical student at UCSF. She looked at 79 children with congenital sensorineural hearing loss who underwent cochlear implantation before 4 years of age. She adjusted for a number of sociodemographic and clinical covariates and found, unsurprisingly, that publicly insured kids had significantly worse language outcomes than privately insured kids. She also found the same thing that many others have found, that if they were implanted late, they had worse language outcomes than when they were implanted early. And the easy explanation here is that publicly insured kids are implanted later. And we did find that in this cohort, right? That publicly insured kids were implanted later. But when we did a mediation analysis or mediator analysis, what this does is it says, okay, well, we saw an association between insurance type and language, but is that effect mediated through age of implantation, right? Or is it a direct effect of the insurance type on the language scores? And we were really surprised. We were surprised to find that actually none of the effect was mediated through the age of implantation, and that the entirety of the effect of insurance type on language was a direct effect on their insurance status. So it wasn't because, and I mean, this is a pseudo-causal analysis. It's not a true causal analysis, right? But this is the best that you can do with retrospective data. And this suggested that, no, it wasn't just because the publicly insured kids were getting implanted later. It's because being publicly insured is a proxy for something else, right? And there's a myriad of other things that being publicly insured is a proxy for. It can be a proxy for income. It can be a proxy for other kinds of access, right? Access to other services, and we'll get back to that in a minute. Okay. So we found that publicly insured families, yes, they have poor language outcomes after cochlear implantation, but not because of later age of CI, right? This brings up other access barriers. We also looked at home language, all right? It's well known that children from homes where they primarily speak a language other than English have worse outcomes. And this was a study done by Katrine Gerada. She was also a medical student at UCSF. And she had a specific interest in immigrant and refugee health. So she did a retrospective cohort study of 532 deaf and hard of hearing children and looked specifically at these endpoints of early diagnosis and intervention for hearing loss. And she was interested not only in home language, but in birth country. Because her hypothesis was that it was actually immigrant status and unfamiliarity with the system and not necessarily language itself that might underlie some of these delays. And she confirmed that, right? So when she looked at age at diagnosis, age at intervention, and the time period between diagnosis and intervention, she found that children who were born in the U.S., whether they spoke English at home or whether they spoke a language other than English at home, had very similar times to detection and intervention, whereas those that were foreign-born had a much delayed diagnosis and intervention. Right. And it wasn't just delayed age of diagnosis, but the time interval between diagnosis and intervention was also prolonged. And now one of the obvious reasons behind this is because many of the countries that children immigrate from into here do not have a universal newborn hearing screening, right? And this is a map showing that, with green showing all the countries that do have some level of newborn hearing screening, and the ones in red and orange and yellow have much lower rates, right? And many of the countries that you can recognize where we have immigrants here into the Bay Area do not have universal newborn hearing screening. But she took things a step further and conducted a qualitative study to try to understand directly from the families what their barriers were to identification intervention. So she recruited 12 families that spoke either Arabic or some dialect of Chinese or Spanish at home, had native speakers of each of those languages, interviewed them, transcribed them, and we saw similar themes arise from all of these families, even across these different backgrounds. She used a human-centered design approach and found that one thing that all these families had in common is that they had difficulty navigating and accessing health systems, not because of the language they spoke, that played a small part of it, but because they were just unfamiliar with the system, and they had different relationships with their clinical providers. They didn't have congruency with their providers. They had trust issues between their community and the providers that they had. So a lot of this had to do with their specific way of experiencing and accessing and navigating the healthcare system that they were relying upon. So when we put insurance type and home language onto this plot, we see that they have very large and huge impacts on language outcomes. But both of these, in those studies that I showed, suggest that insurance type and home language are actually proxies for different kinds of barriers to access to care. Right? Now, access to care means a lot of different things, right? But the insights that we gleaned from the qualitative study, and others that I'll talk about in a minute, steer us towards specific access barriers that we can develop interventions for. So thinking about this model again, right, these demographic attributes, they do impact hearing health outcomes, but they appear to be underlaid and driven by differences in access to care. So the first thing that we then wanted to do was to figure out how we can reliably measure access. Access means something different for different health conditions, even for different systems, right? And fortunately, there already was a measure, a sort of measure for access to care, and this was embedded in the CHIP, or the Children's Cochlear Implant Profile. This is a evaluation or a criterion-based rating that we've had to do for 15, 20 years when submitting requests for cochlear implantation to California Children's Services, or CCS. Right, so for every child that we submit to CCS, we have to fill out a chip, and the chip basically gives a concern score from 0 to 5 on a number of different subscales. One of them is the medical subscale, right? So if a child has normal anatomy and is a good surgical candidate, they get a 0 concern score. If they have a hypoplastic cochlear nerve, they get a 2. If they have a absent cochlea and cochlear nerve aplasia, they get a 5, right? So they have these concern scores already for 3 things that directly relate to access to specialized deaf and hard of hearing care. And 2 of them are related to the education services that they have access to. So one is called educational support services, and the other is educational environment. And the third relates to family barriers to access, right? So family structure and support. Things like housing or job status or social supports or transportation. So Michelle Florentine, who was she was a medical student working with us, now a resident at UCSF, did a retrospective pilot study and found that this Access Challenge Index, or the ACI, which is just a composite of these 3 CHIP ratings that we had already acquired, had a very strong association with language. And so Nima Rashidi, who's currently a medical student at UCSF, took this a step further and leveraged a prospective clinical trial that we're running, that I'll talk to you a little bit later, and did a prospective cohort study looking at the association between Access Challenge Index and language outcomes in deaf and hard of hearing children under 27 months of age. So this is very, very early on. And he found that there was a very strong correlation between ACI and the language outcome, even after adjusting for 18 clinical and socio-demographic covariates that were all collected prospectively as part of the study. And what was most interesting is that when he put this into a multiple linear regression model with each of these socio-demographic factors that you see here, access challenges were the only thing that remained statistically significant. And they were very, very highly statistically significant, whereas none of the others remained significant. And so what this implies is that all of these things are probably proxies for access, and that this measure of access to this measure of access to specialized deaf and hard of hearing care is what we've been looking for as the root and modifiable cause of these language disparities. When we broke down the ACI into its 3 subscales, we also found something interesting, is that the educational support and environment subscales, which measure what the family has available to them in terms of services, did still have some association, but it was the family support that had the strongest effect, right? So the family structure and support, and these are the intrinsic factors that limit a family's ability to access care. So when you put ACI on here, it has the largest impact, right? It has the largest effect on language outcomes. And so we feel like through this phase, right, we've identified access challenges as the primary factor that's underlying disparities in language outcomes. Now, I mentioned that access means a lot of different things, and within the context of deaf and hard of hearing care, there are many, many different aspects of it. And so when we move into the therapeutic development phase, and we're trying to design effective interventions to improve access, we wanted to focus on a few pieces of access that we identified from our stakeholders as being important for deaf and hard of hearing children. And from the research that I told you about before and in talking to the stakeholders, deaf and hard of hearing children from vulnerable backgrounds struggle with accessing hearing at every stage, right? At screening, at identification, at intervention. And 3 of the interventions that I'll talk about that can address these gaps are postnatal hearing screening, speech and language teletherapy, and care navigation. And so I'll talk first about the role of postnatal hearing screening in improving access to screening and identification. So we normally think of newborn hearing screening as the way that we identify most children with permanent hearing loss, mostly sensorineural hearing loss. And that is true, right? This is the principal way that we are identifying these children. But many, many children with permanent hearing loss are not identified through newborn hearing screening. And this is because of 2 things. One is because many children are lost to follow-up after newborn hearing screening. Katie Gutierrez looked at 10 years of CDC data and found that this loss to follow-up is very dependent on sociodemographic factors, as you can imagine. And there are just as many children that develop permanent hearing loss after the newborn period as those that have congenital hearing loss. And Michael Lindenborg, who's a resident with us, found that the same disparities apply in terms of delays for late identified children with permanent hearing loss. Our safety nets for identifying these children in orange are mostly with school-based and pediatrician-based hearing screening that happens after age 4. But most of this hearing loss occurs before that age, right? And we don't have any universal mechanism to identify that. Doing hearing screening in the preschool setting could potentially help with this, but preschoolers are very difficult to screen. And so we conducted a study with the San Francisco Department of Public Health. We looked at almost 7,000 children at their low-income preschools, and we tested basically the gold standard method of hearing screening in children, which is pure tone play audiometry, and found, unsurprisingly, that, as shown in orange, that children under 4 years of age were often unable to be adequately screened using pure tone play audiometry. When we had a second stage of otoacoustic emission screening to catch the kids in orange, they were able to be screened by otoacoustic emissions, and we were able to achieve about a 99.5% screening success rate. However, having two different screens is not scalable, right? It's hard to ensure that a rural Head Start preschool in Del Norte County is going to be able to have both of these types of screens. So we've started a prospective randomized controlled trial. We're aiming to screen 28,000 preschoolers. This is funded by the Patient-Centered Outcomes Research Institute. And we're testing pure tone and otoacoustic emission screening in community-based preschools across Northern California. We're doing rural and urban, public, private Head Start preschools, children who speak English, children who speak a language other than English. We're sending our research coordinators on road trips up to Crescent City and across to the Sierras, and we hope that this project will help establish a scalable standard for universal preschool hearing screening. A second intervention that we're testing is to look at how to deliver interventions better to children. And teletherapy is obviously something that we've learned a lot about, especially over the last 5 years. And we're specifically interested in how supplemental speech-language teletherapy can improve access to speech and language services for deaf and hard of hearing children. And this is another prospective randomized controlled comparative effectiveness trial funded by PCORI. We're enrolling 210 deaf and hard of hearing children. 140 of them are in the randomized trial where they're randomized to receive either usual care or access to supplemental speech-language teletherapy. And then we have a control cohort of 70 higher income children that are receiving usual care to see if providing access to speech and language teletherapy can close the language outcomes gap between low and high income children. We're measuring a comprehensive battery of speech, language, auditory function, quality of life, and self-efficacy measures. We're obviously measuring a bunch of sociodemographic and clinical covariates, and we're taking an 18-month time point after enrollment. We have now completed enrollment of this trial, which is really exciting. This happened about 4 months ago. 74% have completed their interim assessments. Half of them have completed the 18-month assessment. What we're proudest of is that we have only a 3.7% study withdrawal or loss to follow-up rate, and we anticipate the completion of data collection in December of next year. This is a 2/3 low-income, 1/3 non-English speaking population. Almost half of them have some access challenges, and it's we really have an amazing group of research coordinators that have been able to engage a more diverse and vulnerable population of children in a prospective hearing-related study. One thing that we found, however, is that lower income children randomized to access to teletherapy often did not fully utilize it, right? And this is even though they were provided with free 18-month course of teletherapy, an iPad with the cell plan, and so we thought we provided them with all of the technical resources, but even with that, they struggled with actual utilization. And so to learn more about that, we turned again to qualitative techniques. We had this unique opportunity to study 15 families that were randomized to receive teletherapy. They didn't actively pursue it themselves, and so this gave us a broader perspective on the barriers and successes to teletherapy. Half of them were Spanish-speaking. And we're working on the analysis of this right now, but this has helped us understand what families found helpful, and what families found to still be barriers to actually utilizing the teletherapy. And we hope that this will help us in the implementation dissemination phase of the study to know how we can best deliver this intervention. So the final thing that I'll talk about is care navigation, and this is actually what I'm most excited about. Because providing care navigation and understanding what about care navigation has the most impact for these populations can affect all of these phases of deaf and hard of hearing care. And this is because a deaf and hard of hearing child has a lot of care to coordinate, right? They have care from the medical system that includes their pediatrician, an audiologist, an otolaryngologist, a geneticist, a speech-language pathologist. They have care in the educational system, right? Either from their school or their early intervention program. They might have a teacher of the deaf. They might have a speech path in the educational system. And the medical and educational systems don't talk together very well. And in the middle of all of this are the parents that are trying to navigate all of these services that people are trying to provide, but they have a lot of struggles in understanding and coordinating. And so many of these access challenges are rooted in challenges with complex care navigation. This is what families have been telling us over and over and over again. And so this kind of problem is very amenable to human-centered design. So this is a strategy where you use qualitative techniques, you interview families and providers, you identify insights into what might make things better, and then you specifically prototype and you test these interventions. And so Nima Rashidi, he performed this study. He interviewed 12 deaf and hard of hearing providers across multiple systems, 10 deaf and hard of hearing families until he achieved thematic saturation for the study. And he identified three main categories of insights into barriers to care. One is intrinsic barriers, right? This is grief at the initial diagnosis that can cause some paralysis in pursuing care. Home instability, it's hard to deal with deaf and hard of hearing care when you don't have a home. And a poor understanding of the consequences and the reasons, the rationales for the care that people are trying to provide. There are extrinsic barriers, right? Systems-related barriers. Care complexity, wait times, travel, distance, communication barriers of different kinds. But he also identified different opportunities that parents have brought up, right? Wanting to have connections with trusted partners in their community whose children are going through the same thing. Building relationships with their clinicians and some of these other families in their community, and empowering the caregivers to understand more about what their child is going through. And through a design synthesis session, these insights were translated into direct interventions. Okay, so and each of these interventions are things that a patient navigator or a community health worker can provide. All right, these are people who are not necessarily credentialed or medically trained professionals, but they are people that can provide some basic education about care pathways and about the condition themselves. They understand the systems, the medical and educational systems, so that they can provide care coordination. And then they can work with the family to identify these categories of social needs and connect them to social services, either within the medical system or within the community, to address those needs. And so we piloted this patient navigator in our clinic and did a pre and post cohort study with 123 deaf and hard of hearing kids, and found that implementation of the patient navigator intervention decreased the interval from identification of hearing loss, which is when they entered our system, to implementing deaf and hard of hearing intervention from 107 days to 65 days. And we were able to improve the percentage of kids that met the 6-month milestone for intervention from, I think, about 40% up to 90% with this patient navigator intervention. So our next step is to design a prospective trial to test this patient navigator intervention and the specific aspects of it to prove not only the efficacy of the patient navigator intervention, but also evaluate things like cost effectiveness so that it can be sustainable within health systems. So using this translational model, right, I feel like we've identified a major clinical insight, right, that deaf and hard of hearing children are at risk for language delays. We've identified access challenges as the primary root and modifiable cause of these language delays. And we're working on designing specific interventions to address these access challenges. And so I just want to leave with these take-homes, right? Our current standard of care interventions for pediatric hearing loss allow children to thrive. If you are a deaf baby born today without additional developmental delays, and you have access to a cochlear implant and standard of care speech and language services, you are expected to develop language normally. And that's a huge accomplishment that we can do. We can do to anybody who has access to this. The differences in outcomes that we are seeing now, the difference in language outcomes that we are seeing now are primarily rooted in differences in access to care. It's not because we can't do it, it's because we can't do it, we can't get it to everybody equitably. And so our greatest opportunity right now to improve outcomes is to pursue equity in access to hearing healthcare. And I hope that we can all work together to do that. And I thank you very, very much for listening. It's so nice to be here. And I don't know if there's time for questions, but thank you. So this was a picture taken down in one of the clinic rooms with Jasper, who is now 16. Thank you.
Dylan, great to see you.
Good to see you.
Great story.
Thank you.
You know, when I started talking, it's very interesting to me because you don't have to look very far to see where discrepancies in income make a big difference in outcomes in educational development, for example. So look at the Palo Alto School District.
Yeah.
Look at kids who grew up where my kids grew up versus across the tracks in East Palo Alto. They have the same access to teachers and everything, but the family support is very different. So when you showed that slide with the intense, effective family support, and then also said that the kids who got the iPads and everything aren't using them as much. I mean, I can't help but think of intrinsic familial factors, not necessarily access to care, that are really causing a lot of the issues. Can you comment on that?
Yeah, well,
you're looking at that qualitatively right now too, but
yeah, it's like I said, it's hard to focus on, many aspects of healthcare when you can't put food on the table.
Right.
It's hard to make it to appointments when you're working 2 jobs, and sure, we can give you a note, that you can give to your employer, but that's not going to make a difference for many people. And I think these speak to larger societal problems than we can, that we can fix by ourselves. I think there are certainly interventions that can be applied to chip away at some of those things, right? Having greater access to social work services within health systems is critical. We have some of that, right? I mean, we have some of it in our system. I'm sure you have some of it here. Many of the social workers can actually be fairly limited in the scope of what they can do. And, we have one social worker who is covering all of surgical subspecialties.
Right.
And when you think of the commitment of resources in our health systems to different interventions, social workers are probably one of the most cost-effective interventions if we identify. One of the important things, though, is to identify their roles that can actually have an impact, right? And there are a lot of community services, even services within health systems, even within CCS, there are services that we don't really tap into enough or that they're hard to access. So I think identifying what are the social barriers that we can help as medical systems, and then committing the resources to directly affect those, either in partnership with community programs or by funding them within our systems is the way to go.
Yeah.
But we're not going to fix society from this room, but we can hopefully fix some parts of it. Yeah.
Doctor, I'm the PhD fellow from Colombia, the country. Yeah. Awesome. In Colombia, it's completely free to have a CI. It's completely covered by the system. The difficulty is the access to it. So I've had people that have to take a boat, like a 10-hour boat, and then like a 15-hour drive to get to a place where they can have like any intervention. So many kids don't have it because of that. I want to ask is it completely covered in California? RCI is completely covered by the healthcare system? Or
yes.
How does coverage affect what you're...
Yeah, so in California, if you're low income, you qualify for Medi-Cal or California Children's Services, then the entire cost of the CI and the related services is covered by insurance systems.
Does that apply for other states too? So, like for example, my question if it changes between states because of coverage.
There are some differences between states. In general, all states, as far as I know, provide coverage for cochlear implantation. There are definitely differences between states in terms of whether they would cover unilateral or bilateral, or the exact criteria that they cover. But yes, in general, everybody has access to cochlear implants. But these same barriers that you're talking about, the travel and the ability to follow up for therapy, or the ability to call the cochlear implant company when one of the pieces malfunctions or something like that. Those are all different kinds of barriers to care, even though the actual device and the surgery itself are covered. Hey.
Oh, thanks, Dylan, for providing such a thoughtful framework for studying this problem. It was amazing.
Thank you.
One thing that you kind of mentioned a little, although I don't know if you directly said this, is it seems like there hasn't been sufficient prioritization of funding for resources like this that you're talking about, social work. It's just not one of the things that seems like high priority for funding. And I wonder if you have any comments for that.
Yeah, well, I think this goes back to this idea that our field doesn't often think of these kinds of interventions as medical interventions, right? We can perform a cost-effectiveness analysis of cochlear implantation and show that the first cochlear implant for a deaf child has a cost savings to society of et cetera, whatever it is, and that then our health system should fund it. Or we can do a cost analysis and say that, well, if we get this robot, then it will provide this kind of revenue or improve outcomes in this way. Or we have a drug, right, that we do the same kind of calculus for, but we don't tend to do that for behavioral interventions or social interventions. And I think part of the reason why I wanted to talk about this translational research framework for health equity research and for health systems research is that it's the same thing, right? A social worker intervention can be measured in exactly the same way as a pharmacologic intervention in terms of health outcomes. And I don't even just mean what people might think about as soft health outcomes like quality of life or even functional disability. I mean hard outcomes like language, right? Something that is measurable and quantitative can be an outcome that we can test an intervention like a social worker or a patient navigator in exactly the same way that we test a drug. And there's no reason why we shouldn't be able to design clinical trials, conduct clinical trials, advocate and budget into health systems for these types of interventions the exact same way that we do for cochlear implants and for drugs.
I know we're almost out of time, but I have a few quick questions. The chart that you showed that you had SVI, what defines SVI?
Yeah, so the SVI is a social vulnerability index that's developed by the CDC. There are 4 subscales, but basically what it does is it, at the census block level, it takes a look at things like income distribution, race, ethnicity, housing status, environmental factors, and it basically gives a percentile rating for degree of social vulnerability. So it's something that is, it's very valuable because it is generalized and normed across the entire country. So it allows you to compare the social vulnerability of someone who lives in San Francisco versus rural Iowa. And it's what it doesn't give you, it doesn't give you granular individual level information. Because it's census block derived, but census blocks are like a few thousand people, so they're pretty small, and it doesn't allow you to really say which of those individual social vulnerability factors is playing into it. But I sort of feel like at this point, because and you get the social vulnerability index is just a lookup based on your residential home address, and so it has those limitations, but I think given the profound impact of social vulnerability on basically every health outcome, I almost feel like SVI or something like it should be used as a covariate in pretty much every clinical study that's done out there, because you just can't ignore it. It would be like doing a study on hearing outcomes without measuring hearing loss.
I think I really enjoyed your talk and everything you described, and I think one of the challenges seems to be like to really distill out what is it, what factor, what is the family factor or the social factor, and you're looking at all the different things. What about doing a small cohort study where if you have funding, you can compensate families for not just travel but lost compensation? I mean, is that the factor that's driving all of this? Because like you're describing, you provide the iPad and the service and everything, but then what about parental loss compensation? Because some of these families may not have, sick time or paid time off or some of these things.
Yeah, I mean, one of the key things in our teletherapy study was, so everybody has to come in for 3 assessment batteries. And we set our compensation level. So, we reimbursed all the transportation, but we also gave them $250 gift cards for a 1 to 2 hour assessment. We tried to do the assessments remotely as much as we could. We combined their assessments with their clinical visits. We used the assessments that we got from them for clinical purposes. So. We tried to provide that kind of compensation for their.
And did that change anything about follow-up?
So, I mean, we enrolled 210 families, 140 of them were low income, and we've only had 4 of them drop out so far. And so I think we put out a paper on that as basically a model for being able to pull off these kinds of studies, which have been really challenging, right? It's hard to get families to be able to participate in this kind of research. And I think one of the key model or paradigm shifts was not to think about research as something that, to think about research engagement as actually directly benefiting the families, right? Because we're engaging them in care. And the patient navigator model actually evolved out of the research coordinators, right? So the research coordinators were spending so much time working with the families and getting them back into appointments that they were de facto acting as patient navigators. And so we found families that were lost to clinical follow-up because of the research engagement. We found a family that had moved to Mexico and was totally lost to clinical care, but our research coordinators tracked them down and got them back engaged with care. And so to think of research engagement as a way to directly improve clinical care coordination, I think that was one of the big paradigm shifts that helped with this work. Thank you.
Thank you, Dylan.